Hi, everyone, and welcome to episode 132 of the Veterinary Behaviour Chat podcast. So today we're going to continue our theme of just introducing some of the different SSRIs, and I will probably also introduce a few more of the tricyclic antidepressants. So if you want to listen back to a few more of these episodes, have a listen to episode 108, where I talk about SSRIs versus TCA. So what's the difference between SSRIs and tricyclic antidepressants, and not just what are their differences, but also what are their similarities, because there are quite a few. In episode 102, I talk specifically about fluoxetine. Episode 110, I talk about clomipramine. And then just a few weeks ago, episode 129, I spoke more about sertraline. And today is the turn of paroxetine, which is also an SSRI. And as I mentioned in the sertraline episode, it's really important to understand that there absolutely is this sort of big commonality that all the SSRIs share, which is that their main sort of mechanism of action is to increase serotonin in the synaptic space, and in general make more serotonin available in that sort of neuron to neuron communication piece. However, it's also really important to understand that each of the individual SSRIs that we tend to use in veterinary psychopharmacology is also a little bit different. And understanding that will allow us to make much better medication choices. It will allow us to choose one SSRI over the other. Now, depending on where you're practicing in the world, sometimes that can be a little bit challenging because, so for example, if you're practicing in the UK, there is a veterinary licensed formulation of fluoxetine, which is probably our most commonly used SSRI. And it can therefore sometimes be a little bit difficult to justify why you might like to use or start with a different SSRI. But let me give you the information, and then you can decide whether that is enough grounds for you to be able to override that cascade, or whether, you might start with fluoxetine, and depending on the patient's response, you might then quite quickly change onto something else, a different SSRI, and you have a really good reasoning for that. So I talked sort of quite similarly in the sertraline episode about that, and kind of understanding what are the similarities of all the SSRIs and what are the differences. So let me tell you a little bit more about paroxetine. It's actually a super useful SSRI, and one that I quite like using. So of course, we have our common mechanism of action, which is that inhibition of serotonin reuptake into the presynaptic neuron by blocking that serotonin transporter. So we increase the concentration of serotonin in the synapse, and then that has these wonderful downstream effects that take a moment to sort of really start to kick in, which is why all the SSRIs take about 4 to 6 weeks to become effective. And as I mentioned in the sertraline episode, if you'd like to learn more about that, and if you'd like to understand that whole process better, then please do have a look at my PSYCHOACTIVE course, which is a course that's just about veterinary psychopharmacology. So there's like 11 hours worth of content in there. And I have one module that is just dedicated to all the different long-acting medications, of which the SSRIs are only one class. But as part of that SSRI piece, I talk about exactly that. So why does it take 4 to 6 weeks for SSRIs to start working, and what's actually happening at the level of the neuron and neurobiochemically that causes initial side effects, and then kind of the onset of clinical efficacy, and then all those amazing sort of longer term effects from the SSRIs. So that's what paroxetine has in common with all the SSRIs: increases concentrations of serotonin in the synapse. However, paroxetine has at least 2 other effects that are a little bit unique and unusual. So we have mild. Now, mild, it's important to note that this is just mild, but we have mild inhibition also of the noradrenaline reuptake transporter. So we get a little bit of noradrenaline also available in the synapse. So it wouldn't be perhaps as significant as a tricyclic antidepressant, or especially an SNRI like venlafaxine, that is a serotonin and noradrenaline reuptake inhibitor, but it has mild noradrenergic effects. So if you think that you want to be targeting not just serotonin, but also noradrenaline, then maybe paroxetine is a good SSRI for you to reach for. And then this second one is the one that I think is actually really interesting and really useful, and the reason that I might reach for paroxetine over, let's say, fluoxetine. And that is anticholinergic effects. So targets the muscarinic anticholinergic receptor and causes anticholinergic effects. So what are anticholinergic effects? And mainly for the purposes, I think, of, you know, what we're trying to affect from a behavioral point of view, it decreases things like hypersalivation. It might decrease diarrhea. It might decrease frequent urination. And then one really, really, really interesting effect of acetylcholine is that acetylcholine is involved in social pain. So that panic grief, if you're familiar with the Panksepian system, that panic grief behavior that we often see in separation related behaviors. So it's the vocalization that comes as a result of that social pain is often mediated by acetylcholine. So if we have a medication that has a slightly anticholinergic effect, then, and let's say we have a patient with separation anxiety that tends to urinate and maybe defecate and maybe hypersalivate and maybe vocalize as a result of that panic grief, that social pain due to separation anxiety or separation related distress, then paroxetine might be quite a good one to choose. So again, we're thinking of signs. And then sometimes we can have patients that really struggle with stress colitis or that have frequent diarrhea, and we've ruled out maybe all sort of other GI potential contributors. And we think that, you know, that sort of the loose stools and the diarrhea may be related to anxiety. Again, those anticholinergic effects can be useful. We have lots of patients that hypersalivate when they get stressed, especially in those panic moments. So again, you know, those anticholinergic effects could be useful here. And then, like I said, that kind of social pain related vocalization is again mediated by acetylcholine. So again, if you're familiar with Panksepp, you might be quite familiar with some of these ideas, but that you know, that could be a really good sort of patient choice to make. Now, we don't want anticholinergic effects in our older patients because acetylcholine is really important for cognition. So what we don't want is a senior patient that might have early onset or very mild cognitive dysfunction and then give them an anticholinergic medication, right? That's why we also don't want to use tricyclic antidepressants in our older patients, because of those anticholinergic effects that can be detrimental for cognition. So again, we need to know that about paroxetine, right? Because if we're thinking, oh, paroxetine might be a good choice for this senior patient, I would say, let's think about that. And maybe because of the anticholinergic effects, that might not be something I might consider as readily. And then paroxetine does one other thing, which I think we can all forget about, but just for completeness sake, it inhibits nitric oxide synthase. So that's one other effect of paroxetine, but I think we can disregard that from a behavioral point of view, but it is there in STARS. So just wanted to mention that as for completeness sake. But really the two important things that paroxetine does over all the other SSRIs is that mild noradrenergic effect and the anticholinergic effect. So really important to know that piece. So when would we use paroxetine? I've kind of mentioned that already a little bit. So it's quite a calming SSRI. I don't want to say flattening because that makes it sound negative, but when we have a patient that is really, really active in their anxiety, hypervigilant, pacing, panting, hypersalivating, stress poops, you know, stress urination, and I have one patient that fits like exactly that picture, that's when we might choose paroxetine. And I did actually choose paroxetine for him and it worked super well. So what about doses? So for doggies, we start at 0.5 mg per kg once a day, up to 1 to 2 mg per kg once to twice a day. So again, always with the SSRIs, we've got a little bit of a range in doses. We always start conservatively, we start low, and then we titrate up as depending on the effect. We obviously always want to be looking out for side effects. So definitely something to think about. Cats, we can use paroxetine. I have to say, personally, I have maybe one or two cases of paroxetine in cats. And we would start at 0.25 mg per kg once a day, up to about 1 or 1.5 mg per kg once a day. Again, cats usually remain on a once a day dose due to their slower metabolism or different metabolism that you can also learn more about in the psychoactive course. But yeah, so that would be the dose range. And I'm quite deliberately saying range because it is a range. And then what about the side effects? Well, so obviously because of the additional noradrenergic effects and the anticholinergic effects, we can get lethargy, emotional flattening, that cognitive slowing piece because of the anticholinergic side effects. So sometimes that's something desirable, sometimes it's not. So if you listen back to my sertraline episode where we talked about sertraline being a good SSRI for our more sensitive patients that are perhaps a little bit inhibited or shut down, maybe paroxetine wouldn't be the right SSRI for those types of patients because it can be quite flattening. We can get GI disturbances, so reduced appetite, vomiting, constipation. Remember those anticholinergic side effects. So yeah, and in cats, we really need to think about urinary retention, also as part of the anticholinergic side effects, as well as serotonergic effects. So there are side effects that we need to consider. So yeah, like all SSRIs, we always want to think about changes in sleep pattern, flattening, appetite disturbances or appetite reduction, GI disturbances that can show up in a number of different ways. And then we have these anticholinergic side effects. Think about maybe your dogs with dry eye. We wouldn't want to be giving paroxetine to those guys. So yeah. What are the contraindications for using paroxetine? So never to be used concurrently with monoamine oxidase inhibitors, so never use with selegiline. And if you are changing from one to the other, so from selegiline to paroxetine or paroxetine to selegiline, we always need to have a 2-week washout period between the two. So that's important. Paroxetine has a short half-life. It's a little bit like venlafaxine in that regard. So we have to be quite careful with discontinuation or withdrawal signs. So paroxetine and venlafaxine is an SNRI. They both have much shorter half-lives than, let's say, for example, fluoxetine. So if we're weaning off or if we're taking the patient off these medications, we have to wean much, much more slowly. So we have to be really a lot more careful about discontinuation or withdrawal signs. Other concurrent medication use, especially other serotonergic agents, other medications that might have drug interactions, potentially non-steroidals, and there are a few others. So always, if you're thinking about prescribing any psychopharmacology, you have to have a full picture of what the patient is taking. And that's not just other meds, but that can be supplements as well, because there are many supplements out there that are also serotonergic or that might have serotonin precursors in them, like L-tryptophan. So you always need to really ask about, and what supplements are they taking? You know, what are they dewormed with? Praziquantel can also have serotonergic effects. So but that goes for literally any psychopharmaceutical across the board. We have to be mindful of what else is going into that patient's body, diet, supplements, you know, all those things. I think that's probably about it for paroxetine, like the sort of the big basics. But yeah, I really like paroxetine. I think it's a really useful agent. But again, you know, we have to be really cognizant of choosing the patients well. Remember those noradrenergic effects. Remember those anticholinergic effects. And do we want the anticholinergic effects or do we not in our senior patients? And then, monitoring would be exactly the same as any other SSRI. So making sure we get bloods every 6 months and that we are checking in frequently with the caregivers, especially in the first couple of weeks of starting, to make sure that we're asking about side effects. Start low, titrate up. Again, that goes for all other SSRIs as well. And just remember that short half-life. So if you're stopping paroxetine, you have to be a lot more conservative, and you need to watch out for those discontinuation or withdrawal signs. If you'd like to learn more about veterinary psychopharmacology, then please have a look at my PSYCHOACTIVE course. I'm going to put the link in the show notes for you. It is race approved if you're in the US. It is IAABC accredited if you collect CE points through that organization. There are 11 hours of content in there, broken down into modules and bite-sized lessons, so it doesn't get overwhelming, and you can kind of go back and listen to individual pieces. You might be thinking about starting a patient on paroxetine, and you can go back into PSYCHOACTIVE and just listen to the short lesson about paroxetine. So it's a really user-friendly course. And my favorite thing about the course are the quarterly live group Zoom calls, where we all jump on a group Zoom call together, and you get the opportunity to ask questions about meds, about patients, about protocols in general. And they are literally my favorite thing to do. So that's PSYCHOACTIVE. The other thing that I want to mention to you is my Behaviour Case Collective membership. So it's a monthly membership. You can pay monthly or you can pay annually. If you pay annually, you essentially get 2 months for free. And basically every month we do a deep dive into a real life behavior case, and we approach the case as if I was seeing it for the first time. We chat through the presenting signs, the challenges, the problem list, the differential diagnosis, the treatment plan, the caregiver challenges, all those things. And I present the case to you. And then afterwards, we have opportunity for discussion, conversation, and so on. All cases are recorded and are stored in a vault, so you can go back and listen to them. There is accompanying literature. I will be getting guest expert speakers on to co-present with me where it's appropriate to do so. And also the membership has some amazing special offers for members only. So percents off courses and other bits and bobs that you can only get in that membership, not just from Trinity, but also from third-party providers. So it's a pretty cool membership, and I'm very, very excited about it. So I hope that that's something that you might also want to join. So I will put the link to both PSYCHOACTIVE and the membership in the show notes. And I hope you found this episode useful. I think it's always so fascinating to talk about like the individual medications and like what are their commonalities and what are their differences, because I think that is just makes such a difference for when we're choosing meds. Obviously, you have to work within the parameters of your legal systems, cascades, and so on and so forth. But it's good to have the knowledge and the information to make informed decisions outside of that. Okay. Hope you enjoyed the episode. Thank you so much for tuning in, and I'll see you next week for episode 133. Bye for now.